Yeah, so good evening again. Namaste to all our friends from across the world. So thank you for joining us on this EST's Global Web Talk series titled Imaginaries for a Resilient and Inclusive New World. This series of talks has been by leading academicians, researchers, activists from the ground, and also from across the world. And it has been organized to benefit their understanding of the imaginaries we need today for our common good and healthy futures, especially in the context of the pandemic and the lockdowns and the unlocking that is happening across the world. So today's talk is the seventh in the series, and our speaker for today is CHEE Yoke Ling, old good friend of Leo and EST. Yoke Ling will be speaking on a One Health approach to build resilient public health systems in realization to the right to health for all. This especially in the context of what has happened over the last few decades. Countries across the world they were pushed to liberalize their economies and privatize some of the key common services. And this has been happening since the 1980s. And this entire agenda that was promoted by this economic globalization resulted in a whole lot of undemocratic processes where multilateral financial banks, especially the World Bank, the International Monetary Fund, and a whole lot of other banks, came in and they brought in reforms. And these reforms were again pushed with the idea that they would improve the quality of public administration and services, it will bring down corruption, and it will guarantee a better quality of life for all. But it did not do so, and things went completely in the other direction, where private companies, big multinational corporations, took control of practically everything from manufacturing to the global supply chains, managing labor and bringing in different kinds of policies and laws, which were totally unfriendly to the people and to the countries where they set up shop. So along with that came a whole lot of inequalities, and these disparities became very evident, especially after the COVID-19 struck the world. And it kind of opened up all the wrong things that have been happening, from the health sector to the mining of natural resources, to the education sector, to shelter, to labor, practically everything. The kind of inhuman inequalities that was became exposed. And it's unimaginable as to how people had been, going through all this. So despite this, since the last 2-3 decades, the civil society has worked very hard, helping push processes in place, especially in building the United Nations as a public multilateral space, producing commitments to tackle the current challenges of climate change, biodiversity, biosafety, so on and so forth. And in addition, we do have the WHO to kind of come out with their own ambitious strategies and action plans aimed at bringing some kind of inclusion so that everything will reach everybody and eventually a right to health for all. But again, unfortunately, these significant gains were completely lost in the last decade or two. And there have been systematic declines in public investment in strengthening national and public health systems and encouraging a whole lot of privatization everywhere. And even with the WTO, things have not worked as how one would imagine it. And this has had a whole lot of impact on the biodiversity, local traditional knowledge, and how things are being shared, despite the fact that we have a whole lot of international laws and treaties to which India and other countries are signatory. We continue to see a whole lot of biopiracy cases, and many of which we've had to fight at the international level. And now with advanced science and technology, especially with gene editing, things are going to be even more crazy, where we will not even know that some of our resources are gone. Because simple things like a gene sequence, you really don't have to send the species or a sample. The gene sequence can be sent over an email, and somebody sitting across the world can just put together those equations and formula and create those bonds and create these organisms itself. Maybe we are very far from creating complete organisms, but definitely the changes that we need in particular species of food crops or other things that we are using for medicines is definitely possible. And it is impossible to even find out and hold them accountable in the current regimes. So in the backdrop of all these developments, Yoke-Ling will discuss how COVID-19 underscores the right to health, especially to all, and the fact that it can be realized with functioning and resilient public health systems and sustainable and adequate financing, along with a One Health approach that integrates human health, animal health, welfare, and the environment. So to those of us who don't know Yoke-Ling, Yoke-Ling is a lawyer with law degrees from the University of Malaya and the University of Cambridge. She is the director of the Third World Network, an international non-profit policy research and advocacy organization with its secretariat in Malaysia. She was formerly a law lecturer at the University of Malaya and the executive secretary of the Sahabat Alam Malaysia, which is Friends of the Earth Malaysia. And as a firm supporter of multilateralism, Yoke-Ling's work involves various processes in the United Nations as well. She was a lead author in the 5th assessment report of the Intergovernmental Panel on Climate Change in the Working Group 3 on mitigation. Among her current research and advocacy work in public health and resilient public health systems, with a focus on access to affordable medicines, in particular, the national implementation of flexibilities in the Agreement on Trade-Related Aspects on Intellectual Property Rights administered by the WTO. The other focus is antimicrobial resistance and the One Health approach that integrates human health, animal health, welfare, as well as the environment. And today is probably the best day to address all these issues as the world celebrates the World Environment Day as well. And many people may not have been able to join us on time because there are multiple webinars happening across continents. So before I hand over the forum to Yoke-Ling, as a format to most of us who are using Zoom now, request to keep your microphones on mute all the time and key in your questions so that it'll help us take it in order. Otherwise, we might miss it if you just raise your hand. And I think the live streaming is also starting soon on Facebook, and you can request your friends and contacts to also watch this live on Facebook. So thanks again, Yoke-Ling, for agreeing to participate in this and talk to us from your very, very broad and wide experience in the sector. So over to you. I'll share my screen whenever you want the respective slides. Thank you so much.
Thank you so much, Bhagavi. Thank you very, very much to Leo, who's a very old friend. We have done all kinds of fun campaigns, structural analysis, gone through many, many things over the years. I don't think any one of us, and good evening to everybody who has joined this from your different living rooms and countries. I don't think any one of us really imagined even 6 months ago that the world will be as it is constructed today, where we are trying to grapple through really the same issues that many of us are either thinking about, writing about, and being advocates and activists wherever we are. So I just wanted to maybe this, for this evening, my time, just dig into a little more of the, because of, COVID obviously has made us be very conscious about health. I think the ordinary citizen in most of our countries are today talking about, terminology like diagnostics, contact tracing, vaccine trials, phase 1, phase 2, phase 3, things like that, unpronounceable names of medicines that we hope will have some treatment effect. There's been such an explosion, I think, of knowledge, but also with social media, a lot of confusion. So I thought that tonight for the discussion, it would be useful to just look at some of the lessons learned in a way in terms of what COVID has really forced all of us to think through in terms of not just how it affects us at the individual level, at the family and community level. A lot of people in lockdown are really thinking through many, many things, our values, our consumption and lifestyle. I think all of us have ourselves and seen a lot of sharing on social media of people who are talking to each other at home, cooking, even growing their own vegetables and herbs and food, and just doing all the things and realizing how much of the materialistic stuff that we all have been chasing after, really, if you didn't have them, it didn't matter. So I remember that since 1992, when we had the first big global United Nations Conference of Environment and Development, trying to, for the first time, bring together the two sides, environment, economic, social rights, and ecology into this thing called sustainable development back in 1992 in Rio. One of the two key messages that came out of that was that we are in the world of 1992 living in very unsustainable consumption and production, and that we need a paradigm shift. This is 1992. A paradigm shift is in the agenda called, in the document, the big document called Agenda 21, which most millennials don't even know exists, and also the notion of unsustainable production systems, unsustainable consumption and lifestyles. I mean, this was really at the highest level of heads of states, adopted as a recognition and a big commitment to principles around which we will reorganize the world with the leadership of the state and a very vibrant, active participation of civil society. Because that 1992 United Nations Conference was also, for the first time, the whole process, opening up the door for civil society, especially from the South. Because in the past, for the UN system, you had to be very structured, you had to have a membership in a formal way in different countries, be recognized as an international organization before you could have observer status. So all that actually was opened up. And I think the activism of civil society, especially from the South, engaging in the international level and bringing our realities to the global debate was very, very powerful. So that in the early 90s really saw a lot of that very big push. Now, so I want to take a step back in terms of looking at the journey of health. Yeah, one of the things that has really struck all of us, and it's so clear, that the countries, the societies, the communities, the states within federal, federally organized countries, the areas where there have been the most, at least manageable responses, where we have been able to actually preserve some dignity, where the health system is not overwhelmed, where the number of deaths were actually minimized, and where we could care for people. These are the places where a public health system still exists, whether it's Kerala within the Indian continent, whether it's Vietnam, Cuba, Malaysia to quite a big extent, Thailand with its universal health care. So these are the countries where we have seen really the most resilience in terms of responding to COVID from the public health perspective. How do you do surveillance? How do you anticipate infectious disease outbreak? How do you, when it happens, are you prepared? Preparedness is so central to dealing with public health crisis. And here we're talking about infectious diseases. And this is why actually it's very interesting to see it. I'm sure you're all reading about it too. I mean, the gold standard, for example, in infectious disease research and monitoring and surveillance was the United States CDC, the Center for Disease Control and Prevention. And they really, at the in terms of the science, the medical knowledge, the ability to be prepared, to have people on the ground, so that whether it was Ebola in Africa or any of the diseases that would be new pathogens, new viruses that would pop up anywhere in the world, you would have a team organized, not just the US CDC, but through the WHO, a whole international network of sharing of information, of bringing the best in expertise and experience to the countries. And that preparedness for infectious diseases control has been one of the most important aspects of public health response. And you need to do that at the local level, to the national level, and in international collaboration, because as we know, there are no respect for borders, and there is no protection from infection when it crosses communities and borders. So the preparedness, I want to emphasize, is so important. And you cannot have preparedness if you don't have a coordinated, clear alignment and division of responsibility and coordination. And that's why the public health system, where it's still resilient, where it's been supported, where people know there are different roles, you can kick in when something like this happens. And the trust of people, of the community, of the citizens in that public health response plan. And you see the countries which are the wealthiest, like the United States. You see the UK, where since 1948, established one of the first public health care systems with tax base, not just taxpayer, the corporate tax, whatever tax base. And that has been really the hallmark of the NHS in the UK, of the Scandinavian system, in Canada, in Australia. So, and most of our countries in the South, we started off with all public health systems. And yet you see in the United States, it's just blown up. What we see today is there is no health system. It's fragmented, and there's nobody in charge. There's no adult in charge. And the CDC, which was one of the most important institutions, not just for the United States, but for the global community, has been really more or less severely gutted. Not just in the last few years under the Trump administration, it's been happening, right? Because of what Bhargavi was talking about earlier on, the notions of privatization, the notions that the state should step back, that the private sector can deliver better, and somehow putting a monetary value to all services. And a lot of lobbying by a lot of the sectors, and the health sector, whether it's pharmaceutical industry, whether private hospitals, insurance companies, is multi-trillion dollar business as well. And so a lot of the norms, a lot of the ideas, the programs, the laws that you change go to facilitate that kind of privatization and the stepping back of public investment and stepping back of the public health system. So what we see in the US, there's a really good article in The Guardian that just came out last week, where they did a very deep forensics into the NHS and how in the last 10 to 15 years, all the different conservative governments, and even when the Labour Party was in power, they had started some of these sort of fragmentation and privatization, to the point that what's left of the NHS could respond, but the degree of the fragmentation, the degree of the privatization, the degree where the local system of the network of the NHS, where your local district, your county, where those health workers who monitor, respond to the ones who are marginalized in the country, they have been very weakened or they disappeared. So you have maybe 1, 2 generations or 3 generations of public health care, of trust with the community is gone. And so what has happened in the UK, which is so shocking, is that the entire testing and tracing has been outsourced to Deloitte, who then goes and organizes 5 or 6, 7 companies. So the whole thing is private. There is no experience to just bringing people, rushing to train them for a few hours, where before you had people who were rooted in the community, in the health system, who could go and talk to local, because contact tracing in an infectious disease setting, like what we see in the pandemic, is a very sensitive, very human intensive exercise. Because if I am exposed and to somebody who has been confirmed to have, in this case, COVID-19, then somebody has to come to me, or I go to the health system. Do I know who to go to? And I have to then tell the person who is responsible for, or the team of people responsible for tracing whoever has been imposed to the person who's been confirmed to have the infection, and then through me to whoever I've been exposed to, my family, my friends, even other people may not want to know, and I don't want people to know. So it is a very deep, sensitive process where people are asked to reveal a lot. So you cannot do that by having anonymous phone calls, which is what's happening in many countries when it's privatized. You can't just have an app and tell people to just reveal everything if you don't have trust in the system. And yet, without contact tracing and identifying and quarantining and treating, you are not going to be able to have a response. So I'm kind of spending a few more minutes on this just to show that in a setting of not just a pandemic, any emergency of a public health nature, you need to have that kind of response. That can only happen if you have all that preparedness, the people, the resources, the knowledge, the sensitivity to go out and deal with the public health crisis, and to inspire confidence in people, which means you have to train and invest in the health people as well, who are going to be the frontliners and the supporting health people and everybody else in the system. And you have to prepare in terms of mask and equipment, and you know, in the first few weeks, all of us in all our countries, and it became such a global news, right? The scramble for N95 mask. Now, of course, in normal times, we don't go and manufacture lots and lots of these devices, because you don't really need them all the time. You need them in very special circumstances, in ICU, in infectious disease situations, in surgeries. So of course, no country will just be producing it in huge amounts. But if you have a good health system, you do buffers. You always have a buffer. So some countries have a buffer of all this protective gear and everything for 3 months at least. All right. In Malaysia, for example, we have a kind of 50-50 system of a free public health system, which covers about 50% of the population. And in times of economic social crisis, everybody goes back to the public health system, like now. The other half has been kind of privatized. And the public system had a 3-month buffer on all the basic equipment, including the mask. The private sector did not have a buffer that was enough. The private hospitals did not want to take any patients who had COVID, right? In the beginning, when we were worried whether we would be overwhelmed. But it was the public system that organized. In so many other countries where they have been managing, where there is, at least for now, successful managing of the pandemic, is because the public system kicked in, right? And budgets were available, or at least somebody was thinking, and that means somebody with leadership. So the governance of our health system is as important as anything else. And it's not politicians, because in most of our countries, the politicians are not the rule in terms of the ones who are actually managing the system and implementing it. It's the civil servants. And these are long-term investments. So do we invest enough in people in our health systems? That has also come out in a big way. Yeah. So that's what I just wanted to highlight at this point, that we can see across the world where it's so obvious, and rich or poor. I mean, right now we've had debates in Malaysia for years that we should more private, why we should have more social insurance, why should the government keep increasing the health budgets. Not the health budgets in any of our countries are high enough anyway. But there's always this argument, we're just sinking money into this public, mammoth. But now, everyone, including the elites and the people who used to go to the specialists for every little ailment, they're all singing the praises of the public health system. Because in this country, for example, in Malaysia, anybody, whether you're a citizen or not, whether you're legal or undocumented migrant worker or not, if you are sick, the first thing you are taken to is the public hospital. All treatment is done in the public hospital system. Why? So that because they're more prepared and they can do more surveillance, they can do more contact tracing, because the system exists so that we don't have gaps. And we have a lot of weaknesses. We are going through a lot of problems with migrant workers that we didn't pay enough attention to, etc. But this is just an example. And we see it in Kerala, we've seen it in Vietnam, we've seen in so many other countries as well. Well, not that many compared to the world, but enough. Early intervention, surveillance, very important. The same with antimicrobial resistance, right? Before the pandemic, one of the most serious health crises that had gained political attention. I mean, many NGOs in the health areas, consumer groups, we have been shouting and talking about antibiotic resistance since the late 70s, early 80s, yeah? When the whole public health sort of awareness was growing for primary healthcare, preventive healthcare. So for antibiotic resistance, for example, this is something that's not new. It's been in there since the 70s and 80s, when it became very obvious that more and more, because of either misuse, overuse, a lot of the antibiotics were becoming, they were not working for many of the diseases. And because people were not aware, and doctors themselves were overprescribing, and companies were pushing, you know, private GPs and doctors to be overprescribing, when it's a viral infection, which you don't need, antibiotics don't work for viral infection. But whenever you have a fever, you get antibiotics. This is something that I'm sure many of you are familiar with. So this overuse of antibiotics has created major problems. At the same time, we have also countries where millions and millions of people across the South, in many, many countries, and even now with the deep disparity, people who are poor and marginalized in the North, in the rich, wealthy, industrialized North, they don't have enough access to antibiotics when they need it. So even penicillin, which is the first generation, yeah, still works for many, 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 many millions of people in the world where they have not developed resistance, but it's just not available. So we have this very skewed world, like in many, many situations, where you have those that overuse, misuse, and then you have those who need it, who can't get access. Right. So then we are at already, you know, by 2015, the World Health Organization, all the health ministers came together after a number of years of work, because the resistance to most of the antibiotics in the world was so high that we were left with only one or two, right? And we were on the verge that if we don't have a systemic approach to deal with antimicrobial resistance, antibiotic resistance, there will be no antibiotic that will work anymore. And we already have seen the signs where we are back to having gonorrhea, which is killing lots of people. Simple infections, you don't have antibiotics that work for millions of people. You go do a simple surgery or a knee replacement or have a cesarean section to have a baby, and you could actually get antibiotic resistance, bacteria infection, or multi-resistance to even a cocktail of different antibiotics in the hospital. So that's also a big political moment, you know, that resulted in the adoption of a very ambitious strategy and action plan to tackle antibiotic resistance, not just in the health sector, because in the health sector, we've at least had generations of, you know, and trying to understand, to do surveillance and monitor infections and how they are resistant to antibiotics. But then we realized that the biggest users were not really in the health sector, because they were becoming more aware and we had some levels of control, but it was in the agriculture sector, in the animal use. More antibiotics are used in industrial factories of animal husbandry, of livestock breeding, of aquaculture, than it is in human health, and it's totally not regulated. All the surveillance and the monitoring and all the strict rules and all the kind of stuff you have for the health use, and even then we have resistance, is completely almost non-existent in animal use. And so this has become a big challenge of how to get into a sector where there's so much money invested, such powerful corporations linked to political connections, and you can't, in some countries, even get the data of how much antibiotics is used in the animal sector or in the agriculture sector. And there is not really labeling and prescription, which you have to for human health. It's just literally pouring powdered, you know, antibiotics into your animal feed, pouring it into your aquaculture ponds. It is unbelievable. All right, and even some of the very precious antibiotics that are at the frontier of resistance, one of the last few that can be used like colistin for human use, they were using it for agriculture, for animal use. So there's been a huge move to really push that back, right? And in the end, whether it's animal use or human use, everything ends up in the environment, in the sewage system, in sanitation systems, etc. So and there you have interactions of antibiotic resistance genes that get on to other organisms. There are studies that show genetic engineering, which actually then also creates issues around the stability of organisms. You have this combination in the natural environment, you can have more resistance, right? There's a transfer of the resistance gene characteristic into other organisms. So that's why the One Health approach, which is about looking at the dimensions of human, plant, animal, the bigger environment. If we don't have good sanitation, that is one of the biggest pathways for antibiotic sort of spread, resistance spread rather. So bringing together really the natural world, the humans and the animals within that natural world as a One Health approach, and also making sure that we coordinate multidisciplinary words we always use, but honestly really needing to work together so that we can have a better public, animal and environmental outcome. A long, long way from there, but we started the journey in 2015 and not easy. And where you do need to do research in antibiotics, where you need to actually have some potential for antibiotics to be looked at, but you don't make money from antibiotics because unlike other medicines, you can be lifetime, like cancer drugs, diabetes, or whatever. Here is something you want to use very carefully. So it's not a product that you can make lots of profit from. Right, so antibiotics are a very special class, antivirals were a very special class. You want to use it carefully because you don't want to have resistance develop. So most drug companies are not interested. So in 2015, when the big adoption of the WHO antimicrobial action plan and strategy was adopted, then it was implementation. And you see this repeated now with COVID, right? Then you have the US, you have some of the like UK and the European Commission. They wanted to put money as incentive for the pharmaceutical industry to go into antibiotic research. And there was a big hoo-ha, pledges, everybody was talking about how they're going to come in because there was money involved. But it's not so easy. And the silver bullet called the antibiotic may not be the only answer, right? If we are running out of antibiotics that well, we do need to do research, yes, but we also need to take the One Health approach, which is prevention, changing the way we do animal breeding, changing the way we consume meat, the way we build our hospitals, the way we do sanitation, the environmental factor. That One Health approach needs us to really work at a systemic level. So 2 years later, one after another, the big pharmaceutical companies said they were walking away from antibiotic research because it's not worth it, because they did the numbers, even with the subsidies that were going to be promised, and money did flow from the Europeans and from the US, but it was just not worth it, okay? So they walked away. So there are no big companies. Some of the top pharmaceutical companies have said they are closing down or not getting into antibiotic research. So one of the things very interesting that was actually recommended, because part of the follow-up to the WHO Big Action Plan and Strategy was a high-level event in the United Nations in New York in 2015, where a big declaration of heads of states and all that came to give a momentum to implementing the Antimicrobial Resistance Plan. And a interagency coordination group was formed in 2015, and they comprised UN, international organizations, individuals with expertise across all the One Health approach. And it was chaired by Dame Sally Davis, who was the former Chief Medical Officer of the UK government. And a very interesting, they came out with a set of, recommendations to, and governance and all that to sort of push more of the implementation. But one of the recommendations, very interestingly enough, coming from a group that involved a lot of private sector as well, is that antibiotics would actually probably need government production facilities, right? Not just a public health one approach, one health approach, but in providing and doing research and production of antibiotics, we may actually need to think seriously of government production, right? We have lived in the last how many decades where we just put all our hope in the private companies and the private sector to give us medicines and vaccines, etc. So we see that happening now today with COVID-19, that there is this race for the vaccine. Every day, some newspaper, some journal, or will come and say, hope is here. The clinical trials are working, or this medicine may be able to cure. We're all rushing around. We don't see anything that really is, frankly, that optimistic. But already millions and millions have poured into a number of companies, right? I don't know how many of you may have been following. There has been a big scandal around a paper that was published in The Lancet about maybe 2 weeks ago. It was written by 3 leading epidemiologists, virologists, and one person who is a founder of a data company in the US, a small company. So he was also a co-writer. And so they wrote this thing saying that the data company said that we've gotten all this information on COVID patients from how many hospitals around the world, how many thousands of patients, and they've crunched all the data about whether one particular old drug for anti-malaria treatment is hydroxychloroquine, because this is the one that Mr. Trump has made very famous, because he says this is going to cure, I'm taking it. That it's been used by practically every country, because we don't, we were so desperate. This is a new virus. We don't know how to deal with it. So they were trying all the different known antivirals, the HIV antiviral, anti-malaria antiviral. So there's a lot of experimenting going on because people were so desperate around the world, the medicine side, right? But this study really came out and say that this drug is very dangerous. So WHO, which has started a clinical trial with about 80 countries, including many of our countries, people around this talk, they actually, the WHO halted all the studies. A couple of countries say we've stopped using it. I think India is actually using a much lower dosage, for treatment. So everything was stopped. And then a group of scientists, social scientists, physical scientists, medicines, biologists, epidemiologists. This was an initiative started from the Mahidol University medical team in Thailand. And they say, wait a minute, we reviewed the Lancet article. There are some things which are really kind of not very clear. Numbers about Australia, how many people had died or were treated, just didn't tally with the numbers that you know. So what happened was more than 120, physicians, scientists, ethics people involved in clinical trials from around the world sent a letter to the Lancet editor saying there's something very wrong with this data and the analysis, and they questioned it, all right? So this whole thing has now become a huge thing, and there's been investigations, by the Guardian and all that. And it turns out that all the data of the patients and the treatment and the effectiveness of this drug came from this one company, and it's very dodgy. All right. So now there is this other 3 writers of this very influential paper have officially asked for that paper to be withdrawn from the Lancet, which is one of the top medical journals in the world, right? Now, what does this tell us? In the midst of all this, it just shows us how much privatization has gone to such an extreme, where in the past, we will be collaborating and sharing information, right? Whether it's, as Bhagavi was saying, sharing the gene sequence information of a new virus, so that we can all quickly make diagnostic kits, learn whether this virus is mutating. That public information sharing is so important to understand and work together. And if we develop diagnostics or vaccines, or we find treatments, how are we going to make it a public good so that we can deal with the scale of what is required in the pandemic, right? But we have discovered, and we knew this was happening, but this case I just talked about with this data company shows that the data itself is questionable. How did they get the data? How could any one small company, right, within these few months have collected all that data from Africa, from Asia, from Australia, from the US, from Europe, right? Because all these different countries and hospitals will keep the data in different ways, in different languages even. So how can one company have gotten, first of all, access, and secondly, to be able to have this huge database that you can then rely on to do your analysis, which is what happened, all right? And it turns out now as that this whole thing may be really a scam, right? So this is very, very worrying, because more and more when we outsource, it's not just about outsourcing testing or contact tracing, we outsource even the database collection. So the truthfulness, the credibility, the trustworthiness of data for very important decisions, around clinical trials, around treatment, we may not even have them properly. And more, when we privatize and we cut funds in our hospital systems and our research institutions, we don't even collect proper data, right? So there's a big scramble going on, right? So I just wanted to highlight maybe this set of issues. It's a bit all over the place, but just to sort of, these are I think some of the lessons that we are learning, we are observing, just to emphasize that it's very few countries have a political leadership now that can really, in one place, right, in one committee or whatever, in terms of the governance of most countries, being able to understand, get information, systematically respond. And so far I've been only talking about the public health response. I haven't gone into really, the social and economic impact of some of the things that we have needed to do because we wanted to deal with the public health response. And of course, the lockdown, if we have in different degrees all over the world, is really designed not to overwhelm the health system. Otherwise, we're really going to collapse, right? And that has got huge ramifications. And many lessons learned. A lot of people are saying maybe the kind of lockdown that you do in one country may not be the way you need to do in another country. But all that meant that we need to know our country. The bigger the country, the more we need to know the different parts of our country to see what kind of responses we need outside of the public health thing. But this is an emergency, so we all are learning every day. But we need to learn and have faith and trust. If we can't even wear a mask because we don't trust our government when they tell us to wear a mask, then we're in serious trouble if you are living in the United States. Right, I think I'll stop here and maybe, get some feedback and some comments and share some, thoughts around this Zoom. Thank you. And the second half, we can then go a little bit more in some of the actions that are being taken by civil society and some governments at different levels. Yeah. Thank you.
Thank you, Chuk Ling, and I think you touched upon a whole lot of points that have been like really mind-blowing. I'm just curious about the lockdowns itself. So in the context where the public health systems are not prepared, in the context where our sanitation systems are poor, where, soon after the lockdown, people were migrating, I'm sure every country can only afford some X weeks of lockdown, right? And you have to very carefully plan when you're going to have that lockdown. So would you like to comment about how the lockdowns were planned by the respective countries so that they could prepare this entire way of dealing with it? And also what kind of protocols exist within each country, and what were the protocols given by the WHO for the countries to adopt, and how much of it was really adopted? Would you be able to share some information there?
I don't think anyone was prepared. I don't think the concept of a lockdown was something that anybody had thought about. If you look at, but there is a lot of, that's why when I started, I was talking about preparedness, yeah? Because in the public health sphere, especially we're talking here about control of infectious diseases, right? Right. Even if you didn't have a pandemic, you could have you could have quite serious problems, yeah, like rabies, yeah, or we saw, of course. So you have a whole class where you have a novel virus, okay, like Nipah virus or the SARS. Or now this coronavirus. So when it's something new, it's even more worrying because we don't know how it works. So we're not really prepared for it, right? But for many other, but the whole concept of responding to infectious disease situation is quite rooted in principles, in protocols, etc. Right? So what I was saying earlier on about one is early intervention. Okay, so that's why monitoring and surveillance is very important. And that's where you need to, and in a way, when you have a more structured public health system and the reporting, so you have to work it into your system. So if you have a more privatized system, a lot of your private doctors or GPs may not even recognize some of these things, right? And in most countries, when you find that there's been a big scale sort of infection that came out, or even it was if it's a new thing, because the symptoms may be the same. So a lot of people thought it was just flu, for example, right? You have temperature, you have got, whatever. So kind of like a system where your health professionals, your nurses, your doctors at the local level, they know, they can recognize that something, it's the scale of it, or that's some unusual. So that comes really experience and knowing your community, right? And so that's why the kind of health system you have is important. Now, once you have that there's always a delay. Every case, right, which became a very big crisis later on, there's always a delay in the reporting. Like now we have all this thing about, oh, the China, were too slow or whatever, because depending on your country, at the lower level, when it happens, first of all, you may not recognize it. And when you recognize it, you may not want to tell the next level up, or you tell somebody and they don't want to know, so you have all these other, kind of delays. And in cases, and we've seen it happen in China in the first, but when it happened with SARS, I mean, there was really a denial or not wanting the Beijing capital to know what was happening at the provincial level. And there was a little bit of that at the beginning as well here, right, for this one. And the same thing, you had like even Trump himself say, I don't want the ships to come in because I don't want to have these numbers, right? So that is always this denial. So if you don't have a strong kind of public health orientation in your country, you don't react early enough. So number one is your timeliness of early intervention. Secondly, what I was describing about contact tracing, that is like a mantra of infectious disease surveillance and response, all right? That means you have to kick in your system, right? There are people who are going to be able to know what to do, all right? So that you find that now, I mean, honestly, they're training, there is a request from the CDC chief in the US to the Congress just yesterday or 2 days ago, asking for 100,000 contact tracers, right? You don't prepare, you see, so the people who are the former CDC types are saying, look, the whole existence of CDC was to prepare so that the day something like this happens, we can kick in, all right? So this is the health side. Now on the lockdown, I think what happened was because China made the first decision because they were the first to have it on the big scale, right? And they didn't have a national lockdown. They locked down Wuhan city. I mean, it's huge. I mean, you're talking about really, that population is like, like many of our countries put together. So, but because by the time it was sort of acknowledged, it was really quite serious. So they had to quarantine. And frankly, very few countries can do like lockdown in an entire city, okay? They can do it because of the circumstances of what they are. But they didn't lock down the whole country, right? They did Wuhan, and the system was overwhelmed. We all saw it. It wasn't a secret, right? But then they had a system where they could fly, all that, whatever they could do. So they have a better preparedness, right? But you have other cities. We were looking at, for example, very interesting, information coming up from Nanjing city, for example. There was no official lockdown, but they kicked in and did practically all the same thing. The social distancing, right? You don't even touch the elevator. They put, they did all the things that you would do but they didn't shut down the economy, right? But they had serious social distancing and everybody wore a mask. The thing about East Asia is that because of SARS and avian flu and pollution, there is a culture of wearing masks. It is quite normal to do that. So if you don't wear a mask, you are the pariah, okay? It's the other way around in other countries, especially in the West. If you wear a mask, something is wrong with you, okay? So I think this culture of the mask is really interesting, because we go back like the first infectious flus that, in Mongolia and all that. In fact, I'm very proud that actually we were looking at the history of all this. A Malaysian Chinese who, from Penang Island, which is our hometown, went off to China and he went to Cambridge to study. And he, in one of the early flu epidemics in China, he was asked by the emperor at that time to come up with some health response. So he designed this mask. The first idea of a mask was designed by this doctor, right? And so they used it. They used it in the Spanish flu. It was compulsory in the United States. If you didn't wear it, it was a penalty. It was a criminal offense, right? So this is nothing new, right? Now, but the lockdown is something that I think is because there was not, some people say, was it overreaction? Okay, now this virus, it doesn't kill everybody, but it's very, very infectious, right? It's very, very infectious. It is very, very infectious, and that's something we're not familiar with. And because it's new, we don't know how it will actually, we're still learning about it. But we know that it can really be nasty when you are a vulnerable high-risk group. And the risk group is getting bigger and bigger, right? We thought children would be okay. Now we realize that there may be even genetic predisposition. So all this, so I think people think that the whole of China was locked down, and they were not, okay? But they did a lot of things they needed to do. Other countries did. Malaysia did a national lockdown, right? With maybe a few days notice. And India had a few hours notice. Everybody ran home, right? Now, a lot of people are saying maybe that's not the way to do it. Sweden didn't do it. Sweden didn't have any lockdown. They thought that they knew enough of the society. They say we'll be okay. But there are more than 4,000 people who have died. yesterday or 2 days ago, the person who's the health guru, who, because they're a very independent system, he came out and said that he actually admitted that perhaps was the wrong thing to do, right? They didn't want to affect the economy, so they said that we allow 50 people in the public. But in any event, this thing is a pandemic. The economy of Scandinavia, Europe, all affected. So whether they lock down or not lock down, they actually contracted by 3% or something like that, the economy, right? So once it's global and production stops, and this is where you were saying earlier on, Gavi, about the global supply chain, right? What this is teaching us is that we have, in the last maybe 20, 30 years, deepened the global supply chain with all its economic and social and human rights problems. It's become a health problem, right? So it means also that when one part of your supply chain has to shut down for good reason, everything gets affected, right? But I think the other thing we need to understand is that the whole world is not so connected in the global supply chain as people think, right? So there's some real hard-hit parts of the system, but the majority of the world have always been feeding themselves. They haven't been relying on the global supply chain to feed them. So it's the urban areas in our countries which are affected, right? So so for example, you know, I don't think there is a protocol or a step 1, 2, 3, 4. It really depends on your country. So Malaysia had a kind of serious one, and then we started putting relaxation, but we could do it because the public health side was informing. Okay, now you can, these 5 sectors can open, and you have SOP, which is so strict. And the minute somebody said you're going to close down the factory, it's high cost. It's really very, very expensive. So if you start off in a country which is already having a lot of financial problems, right, then you cannot cope with this. Now, Italy is very interesting. I was just talking to a very good friend, because the richest part of Italy was most hard hit. Just before all this, the World Bank had said, now when the World Bank praises any one of us, we know we should be very worried. The World Bank was praising Lombardy as having one of the best health systems in Europe, right? Because it's rich and everything. So they had really a lot of the sort of whatever. But there were also people who didn't believe in social distancing. The government actually reacted quite late. They were all still having their usual life. And then the thing hit. Then you have to look at your population structure, your demographics, right? So that was so hard hit. Now, what was happening was the people in the south were much poorer, all right, from Naples down south. So I was talking to people from the south. They said that, you know what, the community kicked in. They said, look, but if this thing hits us like the way they hit Lombardy, we're all going to die, all right? So what they did was they implemented their own social distancing, community level, province level. The poorer, so you see the poorer parts of Italy have not been as badly hit as that one. And of course, then the national system hit in, all right? So I think the pain of the economics part, I don't think we can run away from it. I think the jury is out. We will be able to analyze more whether people reacted or not. But it's true, many countries in Africa, for example, or even in India, knowing the situation, if we know just the Delhi situation, should a lockdown have been implemented the way it was done? Right, because it was crazy. I think you may be lucky because the transmission wasn't so bad, right? So so people were not sick, right? So they were not like bringing the disease back everywhere, because I think India was, you know, you were probably at a different stage, right? But people were dying more, not from the disease, right? But by just having overnight no livelihood, no food, and having to walk I don't know how many miles, and then go back to the villages, and your elites don't let you in because they think you're bringing the disease from Delhi, right? It happened in so many places in the south. So sorry, it's a long answer, which is not an answer. But it is really making us think, we will have more pandemics, we will have more other things, even not a pandemic at scale, but it really makes us think, how are we ready for social response? And how do we reorganize our economy so that we don't have this kind of breakdown, you know?
Sorry. Yeah, so that's really fascinating about the history of the mass to where we are today. And we will just take a few questions that have already come in. So there is Su Ming Ku, who says, so I would like to come back to connect 2 points Ling made about the TRIPS flexibilities and about the antibiotics. One, health recommendation for government manufacturing. Are any governments really pursuing this recommendation seriously? She asks.
Okay, now generally, if we you see the whole idea of patents on medicines, right? Today, because of this TRIPS agreement, we have to give patents for all products and all technologies as long as they meet the criteria of being new, involved in inventive step, and it is something that you can have industrial application, right? These are the three criteria. It has to be new, you must involve an inventive step, and it must be something that you can use on an industrial, as an industrial application. So if I'm doing pure research and I'm not going to make a product out of it or whatever, then I will not get a patent, because you don't want to stop people from doing research, right? So the idea is actually the patent is supposed to be an incentive for you to do innovation that can bring, products and technologies to society, right? Now, but the TRIPS agreement was the first time, right? It came into force in 1995 for developed countries. Developing countries had a 5-year grace period. Because of our level of development, we were not ready to suddenly give patents for everything, because we had a choice before. You don't even have to give patents to classes of sensitive things, or this against the value of your society. So medicines and food and plants and all these things were never patented in most countries, right? Even patents for medicines, for chemicals, is not that new. I mean, it's not that old, because like Switzerland, which is today a powerhouse of the pharmaceutical industry, did not give patents on chemicals, that's for industrial chemicals or pharmaceutical chemicals, until the 1970s. Why? Because they wanted to be able to do research, right? To do reverse engineering, to work with those chemicals and molecules, right? The molecule. So the Germans, whoever is first out there, wants to have monopoly, so that they, so in the end, it's not about incentive or reward, it's about monopoly, right? This is something that we all know is quite established. Nobody can deny that anymore. It started off in a different way, but today it's a tool to sort of capture the market and, make sure no competitors are there. So if you look at the history of Europe, the Brits were the first, because of the Industrial Revolution, they could start doing using patents. But even then, there was a lot more balance between public interest and the private, And then a lot of things like seeds. Okay, we may not like, many of us are not big fans of the Green Revolution, all right, and all these seeds that came and took away diversity and tied up with chemical use, etc. But even the Green Revolution seeds, right, kinds of things, but there was no patent, right? It was something that was seen as a public good, right? Because it's a seed. But all that has changed a lot, right? So I want to, and because people sometimes we forget and we think that somehow a patent on the medicine or anything is like, it's always been there. We can't touch it. You can't question it, right? So I just want to make the point. It's a very recent thing. It's a human construct, right? Now the TRIPS agreement does not say what is new. It doesn't give you details of the criteria of what invented each country. So the patent law or copyright law or trademark law of a country, you determine the actual standards to us, patent flexibility, okay? That is why you find that some medicines may be patented in one country, but not patented in another country, precisely because a country may have different standards, right? Now for pharmaceutical, for medicines, there are, in the last 10, 15 years, there's emerged within patent law and standards a whole separate set of criteria for what medicines should be patented or not. Now, with the TRIPS agreement, we have no choice. We have to give it as long as it fulfills the 3 criteria. But if I live in a country where my patent law and my patent standards are very loose, okay, I allow most things to be patented, then you find more things locked up. Other countries may be more strict. Now, when you look at a medicine, it's not like one medicine, one patent, right? One medicine can have many patents around it. Sometimes you can have, there are cases where you have a medicine can have more than 1,000 patents around it, okay? So it's not one patent. So the first thing you do when you want to patent medicine is the molecule, right? The compound, the active part. So if you discover, and most of the time, discovery is not supposed to be patented, because the discovery is not something that you make, right? So the patent system, the patent philosophy distinguishes between an invention and a discovery. So when you look at all the natural things and gene sequences and all this kind of stuff, and are we talking about inventions? So genetic engineering has been used to justify that, oh, I should be able to patent a GMO, right? A virus as an engineer or a seed or a plant. But really, what are you doing? Have you actually invented a plant? So this is why some countries are very strict, right? So it depends on your thing. So what has happened is that most countries have allowed all kinds of patents to exist. So if the basic molecule, right, the minute you patent it, and most of the time, if you get there first, you have to go to every country to patent, because there's no such thing as one international patent. That's why they will have to go to every country, and apply for it. But after that 20 years, that molecule may expire, and then anybody can work with the molecule. But in between, there will be other patents that they will be applying for. And you can apply a bit later, can apply for more, very broad, all kinds of things. So you basically lock up the whole medicine. Some countries, most countries even give you, if you change it from a syrup to a pill, you get another 20 years. You do 20 milligram and then you have 40 milligram later, you can have another patent. You combine A and B into one pill rather than take 2 pills, you can have another patent. So you can do what we call evergreening, all right? So one drug can be locked up for more than 20 years through different patents, right? So this has become a huge issue. It exploded with HIV/AIDS in the 1980s because the first drug that was usable for HIV/AIDS was actually an old drug, which was used for something else. And then doctors who were treating people with HIV in the US realized, hey, this person has HIV, but seems to be getting better while using this medicine for something else. So they reported this information. So it's a discovery of a new use for an existing drug, all right? So they reported back to the drug company. So then they did trials to make sure that it really is targeted and it works for HIV. And then they got a new patent, another 20 years, and they charged an enormous amount of money, all right? It was something like 10,000 US dollars a year, right? Nobody could afford it. People were dying. That's why it exploded. The access to medicines movement was because of the patent over the first HIV drug, because it could cure, right? So since then, we have got so many of these problems. And you have some countries, for example, like Thailand. Thailand has its own state-owned pharmaceutical facility. They also do research. They do a lot of generics. Indonesia has its own government-owned, one of the biggest. In fact, Indonesia has this particular biopharma in Indonesia is one of the biggest vaccine for flu. Yeah, one of the biggest vaccine producers. They can make quite a few million doses. Okay, so you have, and then Malaysia has some. India certainly has. India has a lot of vibrant generic industry. Why? Because India had a very cleverly crafted, you didn't allow medicines patents for a long, long time. And even with WTO, you managed to really, have a system that was consistent with the TRIPS agreement, but would also be, supportive of your own industry. And then you go into more research yourself, right? Of course, now you have the big guys coming in to buy the Indian companies for the last 10 years, and you have another story. So yes, so what is happening now is that most countries were not aware, governments, were not aware that they could actually have tighter intellectual property laws that would reduce the number of unnecessary patents or frivolous patents, right? Or if somebody makes a drug that's just a little bit different, a little trivial change, and then they come and ask you, or they just make a little bit, I'd say, for example, right now, Gilead, which is very famous for this potential, COVID-19 drug, remdesivir. It was developed. It's not, it was developed for Ebola. It didn't work. They tried it for MERS, it didn't work, all right? So now they're trying it because it's an antiviral, they're trying it for COVID, right? And the clinical trials are going on, but nobody knows whether it works. It's not a new drug. And they didn't even bother to apply for patents in most part of the world, okay? Because it wasn't working, nobody had to prove it for anything. But now because of COVID, because the potential, this could be it, could be one drug you could use for treating symptoms. And the United States have given it an emergency use for this pandemic. And everybody wants to buy this. So around the world. So just today, a patient group in Argentina has filed an opposition, right? Because I think Gilead has put in the number of applications, and the am I still there with you? Yeah. And this Argentinian group patient group has filed an opposition to protest against this. Yeah. So whether governments will respond to take up a role in production remains to be seen. And I think this is one of the looking forward that COVID-19 may, I think, has shown most countries, especially middle-income countries, you can't buy the drug because the number of drug companies, factories for vaccines and other things at the pandemic scale, there will not be enough supply, right? There'll be a shortage, just like with masks, right? So suddenly everybody is realizing, what is my capacity, right? And for many years, because of TRIPS, our local companies in many developing countries, they could not commercially survive. because they could not get generics in early, or they never expanded, they never gone into the higher level of, let's say, making vaccines, right? So our capacity for manufacturing in the South is generally quite weak, right? Except for maybe China, India, Egypt, and then maybe Thailand and other for some things. But on the whole, not so. Maybe South Africa a little bit. So I think the wake-up call for us in the South is that we need to really increase our own capacity to do, not necessarily in each country, if we are small countries, but to do South-South or regional, because it's very investment intensive, right? But we can, because we all have public research institutions. Right now, there are more than 180 teams, right, working on trying to find a vaccine, and many of them are public. Even these big companies that go on and on and on, all the basic research are actually funded by the taxpayers. In the United States, every drug that was a blockbuster actually had the first years of basic research paid for by taxpayers. And then they take it to the commercial development, clinical trial, and then they put the patents, right? So that's why in the US, before the pandemic, high prices in the US has become a big scandal. Because if I'm a US taxpayer, I'm paying subsidy for the research. And then you go and patent it, and you're selling it back to me at a very high price. So I'm paying twice, right? And you can have a generic for 100, and the originator can be 48,000. I mean, that is really unacceptable, right? So whether we will have more capacity to produce another is a challenge for us to demand of our countries in the developing world. How do we now have a policy on production, on research, you know, on the most basic things we're importing is ridiculous at the moment.
Thank you. I think Leo wants to ask a question directly. Leo, would you like to ask your question? Leo, are you there?
Yeah, I'm just unmuting it. Thanks, Yoke. This is like I don't know what to say. It's mind-blowing, everything that you've said, and bringing us so close to the real picture of how frayed our public health systems are. My essential question is that since the push of neoliberal economic policies across the world, what we have gone against, as you rightly say, is the fundamentals of keeping the earth healthy and human populations healthy. We have worked against it. And what we now have is the rule of parastatals globally, who are unaccountable in any democratic sense.
Yeah.
But they have got the backing of the administration, which has become highly centralized. And we see the administration, and the collusion is direct. It is not even that they are making an effort to hide it anymore. Now, this kind of situation is there everywhere. And there is resistance everywhere. We see resistance coming out in many different forms. How do you see these resistances coming together globally? Because the virus is telling us a simple story. It's saying that you have basically, with all your intelligence, gone the wrong way. So how do we turn this around and bring it back? And how do you also work, how do you work all these resistances together to ensure governments are what they're meant to be, to serve the public and become public servants?
Yeah. Well, I think that's where we like to go. I mean, what you're saying is where we all have been pushing for, right? Because the corporate capture of the state, and even at the international level of the international public institutions, whether it's WHO or different parts of the UN, it's a serious one. It's something that we all have been very concerned about. But I think we have to be also very, very open-eyed, that the big economic players, right? And they're not just companies in the pharmaceutical sector or the food and agriculture sector, but they're all talking about the finance sector. And now you have the Googles and you have the Facebook. I mean, so we have an economy today that is not just about the production. This digital economy, but everybody is was so enamored about. We have real, I mean, if you look at the Amazon and all that, they've displaced a lot of real, people's services and people's small businesses, the Ubers and all that. I mean, that already was coming up before the pandemic, right? And so what you see is that these big players, including all these big banks and the Deloitte and all those players, rating agencies, they're not just going to sit down there quietly and say, hey, you know, this whole pandemic is showing the system is very fragile, therefore we're all going to have a happy new world. They have to keep themselves alive and thrive, right? So I think we shouldn't be under any illusion it's going to be easy. All right, I don't think any one of this thing is easy. I think we need to understand, as civil society, academic research wanting to link to action, we need to really understand who are all the different players and who are the ones influencing thinking, right? I mean, what you just said, Leo, you know, that many of the people who are in political positions, they are not acting in the public interest, okay? So it's not just, sometimes it's not just a direct, you know, it's not a direct collusion, but it's just the whole mindset of this is a way to do things, you know. So I think I think the challenge is for us on the civil society side. I mean, I'm using civil society in a very broad sense. So people who are working on different issues are now also trying to come together and think, how do we take advantage of this kind of disaster, right? To move forward. It's not a simple, you asked me a very difficult question, all right? I think that when I see right now, a lot of the economic stimulus or recovery packages, is very worried about, yes, because the social thing is so in your face, no government is ignoring the social needs, right? But they're very temporary, you know, little payouts here, and you can't keep doing that. But they're very worried about the tourism sector, for example. Tourism in all our countries is dead. I don't know when it's going to come back, right? But you see some of the new packages announced by countries, it's so much of it is to like, don't pay taxes in the tourism sector and this and this. I'm not saying that there are no sufferers in the tourism sector, there are. But you know, to sit down and say, what is our economic priority, right? How do we bail out the big guys, yeah? The big guys are very influential. And some of them will have to go. I mean, Lufthansa was just bought by the 20%, I think, or something like that, bought by the German government, right? So it's like the financial crisis in 2018 or 20 or whatever, right? You think that if the big guys fall, you think everything will collapse. So we've got to save the big guys, yeah? So I think each of us in our own country need to be part of that discussion, and the governance and the mechanisms don't exist most of the time for us to be part of the discussion, right? So a few people are deciding how to recover, right? Now a lot of it is about economic recovery, and it's going to be a lot of the same thing. It's going to be a lot of the same thing. I mean, recently, the Indian government had already, before all this, you know, on the 1st of January or something, I think you were going to start doing a tax on e-transactions, right? On e-commerce, e-transmissions. It's a very big issue, very big issue. And now yet all the big guys like Google and Facebook went to the I think to the Prime Minister, very high level, to say, don't implement it. And the US administration is now saying that India is taking advantage of the pandemic to try and do this, which is not fair to my companies, right? So that is still going on, right? WTO, they're still trying to do virtual negotiations, you know? That's why we have had a huge campaign from the trade and social human rights groups saying there should be a moratorium on all these trade negotiations. We cannot be negotiating when our governments are so busy trying to, you know, firefight. And we don't have Zoom that works all the time. And so there are things like silence procedure, you know, if you don't disagree means you agree in the UN for resolutions. So there are implications, right? So decision making is going to be very virtual, but what does that mean? So I think it's not so much how we're going to, you know, it's just that the response from the other side is also happening, right? So it's a free for all, and in the end, the accountability, the public, coming back to the public system means that we have to, how do we get to our own members of parliament, our own politicians and our civil servants? Because a lot of the ideas are actually in the civil servants, right? Who have never been really so I'm not giving you an answer because I don't, it's not easy, right? I think some countries may be easier than others. In fact, I just say very interesting, like one of our senior health official who's been the one man who has been really the adult running the thing and giving confidence, and every day he gives briefings. So he is interested now to invite, for example, you know, some of the key ministers who are hands-on, right, at the state level, you know, the other people. So so I think we need to do that. I think we need to, as a society, work with the people in our government in different ways, at the state level, at the local level maybe, and some of them at the federal, central level. Identify that group so that we can together think through what kind of, not just a public health response, but also the economic things. Because see, civil society has been amazing in all our countries, right? Civil society and NGOs have been the ones to help governments actually do delivery, do monitoring, and really fill the gaps on the ground, including feeding people, right? So, but when it comes to the policy side, you know, we are not so much there, and I think that's the challenge to ourselves. How do we find new mechanisms to reach out? Because the other side is very influential. I mean, you know, Bill Gates is still calling out, and with the US, by the way, walking out of the WHO, the single biggest funder of the WHO is now the Bill and Melinda Gates Foundation. Now, when you are a private foundation that actually is a corporate, basically a corporate entity, right? That's where the money comes from the monopoly of Microsoft. Now, what does it mean? Where is the influence over decisions at the international level or the national level coming from? It's still the same. All this, you know, what we talked about as the power, you know, the imbalance of power, it's still there. And in some ways, they're even more influential, right? But at the same time, the whole health and social impact of what we all gone through means that all our citizens, you know, not all necessarily, but at different levels, have just also woken up to many things. People are going to be demanding, right? How do we carry that demand in a way that is going to turn into policy decisions and all that? So I think that depends on each country and how we have to work together on issues. For example, the question that I think Su Ming raised, to do all that means that we will, many of us have been working at a different level in our countries with the generic industry, with our domestic industry, with those who, of course, they want to make money, but for whom profit isn't the end of everything. They also have something more to the country. They also have a public conscience, right? You have people like that. So we need to set up, let's say in the medicine side, can we get the health ministry, the finance ministry, the trade people, intellectual property office to sit down with people, civil society groups who are thinking about this, academics who have been working on this, and our local industry, and say, what is our national pharmaceutical policy for our health, you know, system, right? How do we, so we can do that because it has been happening at different levels already, right? And I think that's what we need to work on every issue, on food, on medicines, you know.
There's another very interesting question, and you also did mention about how everything is getting outsourced, from contract tracing to testing to everything is like being outsourced to companies like Deloitte and Ernst & Young, perhaps, and many others. So in that context, there is a question here about, she says she has to leave. This is Susan, but about data collection itself and the mentioned in the context of the Lancet article. And, how can we use analysis in a more reliable and accountable manner, and which does not require randomized trials. I also have, in continuation of that, now the World Bank is called for the World Development Report, where they say that the role of data for development. So, which means integrating a whole lot of public and private data, and they're going to obviously outsource this to all kinds of companies. And we've already seen in India where companies do this for a business, and the quality of data that they will be collecting is not up to the mark. And the people who are designing the tools for the collection of data don't necessarily come from the social science or related backgrounds. So how do we deal challenges like this?
Yeah, I think this whole data, in fact, you should have probably another session just on this whole issue of data. I think IT for Change is your next guest. No, it is very worrying because one is the issue of the privacy of data and also the ownership of data. I think the privacy of data has been something people are more familiar with, but the issue of ownership of data is really important. And that's why the one of the most controversial negotiations that is not getting so much public awareness yet, is happening in the WTO. an agreement on electronic commerce, right? People think e-commerce, many of our politicians think e-commerce is about, Amazon, our own local Amazon equivalent, we're buying and selling. And actually in this period of the pandemic, all governments are thinking the way to boost up our local businesses and other is to get, and a safer way of transaction is to we all should do more e-commerce, right? And that will be the way as part of the recovery. So, but there are huge issues around ownership of the data and also unaccountability. Because what we are seeing, I mean, this thing with the Lancet thing is not the first time, actually, this is only the tip of the iceberg. We have had many of these things coming up before. So how do we know that? And then they come and say, oh, I can't share the data for verification because I've signed all these confidential agreements with the suppliers of the information, right? In this case, the hospitals. But in this case, so when they actually say we'll do a peer review audit, yeah, because of these things because it influenced what the WHO did or did not. I mean, the WHO stopped all the trials, right? France and a couple of other countries, I think France and the UK, took it off the treatment list. Now, I'm not saying it works or not work, that's a separate issue, but if an article can have such influence, right, it better jolly well be something that can be trusted, right? So now it's not so much about whether they had good data and did a bad analysis. Here it's about the data itself. And there is no, and most countries don't regulate because this is a new area, never thought about it. And so that's why these big companies, the big guys are playing the rules, all right? And these little guys will benefit, right? And the thing at the international level has been a huge pushback from 5-6 years ago. I mean, the big platform companies have been pushing and pushing for no regulation. They don't even want to have a requirement to set up to register in your country. So for example, Facebook, right, can say, or Google can say, I don't need, because right now, if any foreigner wants to come and do anything in my country, you have to register, right? So that if something goes wrong, I can go for you, you have a legal entity, you have a legal presence, you pay taxes. They don't want, they say this is a digital economy, we don't need that kind of stuff, we want a flow of data. But then the data flows to you and then it becomes your data, right? So there is a lot of problem. And I think governments have allowed these horses to leave the stable and now they need to pull it back. So and all this data are very expensive, very, very expensive, okay? And if they are not even real or trustworthy and you're paying all that money. So it means a lot of public research now has also been affected. Because first we squeeze our public research institutions, we don't give them enough money. And then more and more good data, good analysis, lots of literature, it's all copyrighted. If I don't pay $30, $40, $50, I can't even read an article. So you are shrinking innovation and R&D. And that is part of the whole, it's not just about patents, it's about copyright, right? So the whole supply chain of knowledge has been so kind of privatized, and made private property. So I think that has to shift. And it's becoming, that's why open source and all that has been happening, right? And peer review is, the scandals around peer review, whether it's climate change science or pharmaceutical or clinical trials, we know there's been a lot of problems, okay? It's a very insider thing. So we need to really, that's why the way you can have transparency and accountability in research is public accountability, right? The minute you say secret, confidential agreements, private property, then it's not that you are making something or taking something away. You can even do fraudulent things. You can lie, you can make up data. Right? You can just get data from 5 hospitals and then use AI, whatever AI is, and crunch it and make scenarios, and then say, I have, who knows what they're doing because there's no regulation, right? So I think it's very, very dangerous. And I think if one of the things that we are hoping that this will be an eye-opener is about what data means, what the digital economy is all about, and we better stop all negotiations of the WTO e-commerce treaty, because all the provisions that are in there being contested is going to give us more problems. So join us in our campaign to stop this horrible new agreement from coming to life in the WTO. But we need to scrutinize. Look at, there are privacy issues, there are Twitter, Facebook, they are not accountable, right? It's a big problem. Somebody had an issue about, Kerala and all that. I saw some of the comments. Yeah.
So Anthony says the epidemic control community involved surveillance testing, and
I think
Kerala.
Yeah.
Shiv Kumar has a question. Shiv Kumar Srinivas. He says, "Thanks for the informative presentation. Looking ahead, recently I heard that in
Brazil
already talk of advocacy and push.
Yes.
So maybe on that."
Yeah. Actually, some of the things, so many things that we are asking for in everyone. I looked at your previous discussions in this series. I mean, we're not asking for anything new, honestly, right? What we're asking for is so commonsensical. It's something that's been tested. We're not the first to ask. It's been something that, generations of people have been talking about and actually doing it also in many parts of the world. Now, the thing about you see, what was interesting was at the World Health Assembly, because they couldn't do it, right? So they had this virtual one for 2 days last month. And you had a few. You had China's president, you had Macron, you had at least 3 or 4 heads of states use the term global public good for a new vaccine when it comes out. People's vaccine has been out there. So what is interesting is that for a long time, the pharmaceutical industry divided the world up, okay? The high income country, we just go market. We just charge as much as we can. That's why all the first drugs are always registered in the United States, because it's calculated that that's where the market can bear the most because of the way the system is, the whole insurance and complicated system of, healthcare in the US. So the rich countries always, you charge them as much as possible. Then you divide up the whole world, middle income, and now and then of course the poorest countries, somebody will always donate to you because they're not interested in selling to these countries anyway. So it's a very carve out of the world in terms of the market for pharmaceuticals. But what is very interesting is before this, there was hepatitis C, where there was a drug that was actually cures, in 12 weeks at an early stage. But it was so expensive for the developed countries. Even the developed countries were becoming like, this is untenable. The former health minister of the Netherlands actually did a testimony to a UN high-level panel on access to medicines and intellectual property. And the Dutch health minister at that time, she said, I cannot afford to use this medicine to treat Dutch patients with hepatitis C because it's too expensive. All right. So there was a movement of the access to medicines groups around the world, and even countries like Netherlands was talking about doing compulsory license. In other words, if I can't get the price down to a reasonable level, and the patent holder company does not want to allow other generic companies to make the same product with their permission and pay them royalty, they don't want to do that, then I will force them to do it. I will give a license to a generic company, and they can make the drug, and they can pay some royalty to the patent holder. So this was actually moving. If you remember the beginning of this pandemic, Israel thought at that time there was an HIV drug combination that might work called Calitra, but very expensive. It's patented. It's an old drug, but still patented in some countries. And so Israel actually issued a compulsory license so that the government can go and buy the generic version for treatment for COVID-19. All right, they did it. They actually issued a compulsory license, right? So I think this whole COVID-19, and this has started with some countries even before, I think the richer countries are realizing that they can't sustain these crazy high prices, right? And in many diseases, they're not even finding that people are doing research. And more and more, we are all getting non-communicable diseases like cancer, diabetes, hypertension, right? These are lifetime drugs that you need, and they're very, very expensive. So I think the world has come to the stage where it's, so the whole thing about the 80s, where we had the People's Health Movement, we had the social determinants of health, where we were talking about even primary healthcare, prevention, all these are going to come back. It's going to come back. I do believe it's going to come back. And I think we have to make huge demands for them because, like I said at the beginning, this whole pandemic is showing how unprepared most of the world is. And even if I am prepared in my little country or my little state of Kerala, if the rest of the world doesn't take care of the situation, we are also going to be jeopardized, right? So this is an international project. It really is. It really is. And the answers won't lie in a few companies. It won't lie in a few companies. It cannot lie in a few companies. And the shamefulness of everything is that it is we saw more selfishness than we saw solidarity, right? Of course, in a world where we don't have enough, your immediate reaction, which is very normal as a country, is that, do I have enough for my own people? All right. So this whole debate about should India have banned some of these medicines, right? Malaysia, we banned the export of masks. We didn't make N95. We were making the surgical masks. We had 3 factories. We banned the exports, right? So the first thing to do is that, because you don't know, because what I find interesting is because we have also privatized most of the production in all our countries. So the government doesn't know. See, we have buffer stock and stockpile, right, for food, for example, or certain things. But we never thought about it for things like medicines. Do we need a stockpile for medicines? I don't think countries really have that, right? So if you do your own production, so Thailand was more, I think they knew how much they had and all kind of stuff. For us, it was like, wow, you know, if China continued to be, let's say, not recovering, and they are producing so much of the raw materials for everybody to make their drugs, what's going to happen if that's not going to come? So how are we going to do? Because, you know, so people will, wow, you know. So the global supply chain, our own security, from medicines to food to everything, we have to think about that. And if we are more prepared in terms of also supplies of important medical devices and medicines within our country, within our region, that's part of the preparedness. If we're not, then I don't blame any country by saying, I will ban first, right? Make sure that I've got enough for my own people, right? And then if you are so privatized in your country, you may have to nationalize. I mean, the US was talking about nationalizing part of the global supply chain if needed, right? Telling the company of the US company that make the mask, a huge company factory in China, they say your mask can only be for the United States, right? I mean, we were finding those, you know, those N95 masks have more than 400 patents in the US. We were still digging up patents, you know, more than 400. The design, the little valve, the shape, you know, it's incredible. What is so difficult about making some of these things? Okay, honestly.
Yeah, so there is a question from Narendra, who says that, you know, most of the countries should be having disaster management acts and manuals. And yes, India also did have, and that is the provisions of the Disaster Management Act was what was actually used. But our disaster management cells across the country were dysfunctional. A few years back, the budgets had been pulled out. Reduced. So obviously they were not in a position to kind of, you know, step up to the demands. And also he says that must be epidemic management manual, which is hardly so in this context, I think if you can commend both the use of the epidemic management legal provisions and the disaster management provisions from the examples we've seen from across the world.
I am not so familiar with this area actually, but you know, I'm sure all countries have, because you know we all have to manage all kinds of disasters, right? Climate change, extreme events. I mean, if you look at sometimes when we don't pay attention, we don't think it's going to happen to us. Any of these disasters, right? Natural disaster, disease, you know, whatever. When it hits us, that one time it does hit us, and we realize because we didn't plan, and we were not prepared enough, or we had something that you know, the plan was on paper, and then we never actually had the system. So when we get hit by that disaster, we're going to hit so badly. All right, it's like like a cyclone or a hurricane. Right, if we don't think about it, we didn't think it would happen to us. But after it happens and we pay a high price for it, what do? We kick in, and we're going to have a much better preparedness. We see in earthquakes, we see in so many different things. All right, you talk to the people in the islands, in the Pacific or whatever, they live with the cyclones and the hurricanes. You know, it's part of and it's getting more intense, but they are vulnerable, but they've also had no choice but to be prepared in different ways, right? So, and I think in India, you've had a lot of that experience too. So I would say that what this has shown us is that we all in our countries have different types, different degrees of disaster management policies or laws, and they may be very good on paper, and we don't have them, we've got to have them. But then we have to have the actual mechanism. We have to have coordination, and we have to be preparedness. So the preparedness is very important, whether it's for a cyclone or an earthquake or an infectious disease, all right? We have to be prepared. And how can you be prepared? We're back to the public system, because no private sector will invest in these kind of things. They don't make money, okay? It's a public responsibility. And if you look across the world, you know, the public funding from the NHS to the CDC in the United States to everything, right? So what we describe, I think, happening to us because of structural adjustment, forced austerity policies from the IMF, you know, these rich countries did it to themselves, because of this ideological belief that, you know, the state should play a very minimal role, not even be there, right? But what happens when you have something like this? It's a reminder that you can only deal with huge scale crisis with a coordinated huge scale response. And the only way you can have a huge scale response is you have to have a systemic response. And you know what, if you have a very weak public system, it also means that most of the time you see the same pattern. You will have also very little citizens trust in the system, right? And then they won't listen to you. No matter what you say, they won't listen to you. So building that trust with your community, with your citizens is so important. And you know, even if you have the best plans at the central level, if we don't invest in the network on the ground, at the district level, at the community level, and it's not just the public servants, it's also people, right? If we don't have that, and this is why we're hearing, like in this country, our health director general is saying, this is a common responsibility. We have to empower our society because we have to all be part of the response and the solution, right? So they need us. They just need to listen to us, maybe say something different. But I think all politicians are very scared, all right? It is very scary. So whoever goes there with a solution that seems simple, but you know.
Okay.
A lot of work to do, a lot of work to do. This is the moment for the real public health movement.
So Giridhar says healthcare is under severe stress and structural rigidity. There is no stretch it too far and see it collapse in India. All of a sudden, this pandemic is around and no point in pressing panic button. That's a comment from Giridhar. And then Anthony also says, talks about the international agreement under patent regulation, given that, you know, so many times more the actual product research and cost. So,
well, yeah, actually, you know, what we should do is go back to the pre-TRIPS days, right? I mean, before the TRIPS agreement, I mean, you have total policy space. You can exclude entire sectors from being given this kind of monopoly. And if you choose to give, you can give different number of years for different things, right? I mean, for example, even people in the IT world say, look, 20 years for, you know, in the IT world, things are changing all the time. What's the 20-year thing? They're constantly changing, right? So this thing about making everything one size for everything, you see that the number 20 came from the pharmaceutical industry because they were complaining that not enough time for them to recoup from their heavy investment, right? But now there's a lot more literature out there because best kept secret in the pharmaceutical industry is how much it really costs. Right. We don't have time to look at one of the slides that I have put in the thing. You know, this is a very well done thing by a team in the University of Liverpool and a whole bunch of people. I mean, this is one drug where Gilead, you know, who is also now the COVID-19 fellows, they actually didn't make the drug themselves. This drug was developed by a small biotech company in California. And then they got money in the beginning from public investment research. And I think they spent about 118 million or some 118 million, it's called PharmaSet. So they brought the drug actually to phase 1. So they got it registered and it worked, right? So then I think they even went to phase 2, or phase 1 anyway, human trials. So then this was it, right? This is going to be a drug that's going to, you have to take it with something else, but it's a backbone drug. It would cure, right? It would cure hepatitis C. Can you imagine, right? And so there was an auction. There was an auction to buy this company. And Gilead outbidded everybody else and paid, I don't know, 11 billion or something like that, right? Without selling a single pill. Once they bought this company, their shares went up. Just as we don't know whether remdesivir will work or not, but the shares was going up for Gilead in the first few weeks, you know, of the pandemic. And they so they then charge, you know how much they price the drug in the US, which is the first market, $84,000 US for 12 weeks, one pill a day, $84,000. Okay. Now that I think is a little bit expensive. Okay. So this slide that I had shared, basically what is it? Okay. So they didn't do anything. They took it to the last stage. They bought the thing, and then it was approved by the FDA. The drugs were started to be sold around 2014, 2021, right? In the first quarter of the sales period, they got $2.3 billion of revenue, 2.3 billion in the first 3 months. Okay? In less than 5 days of sales, they recouped actually the amount of money that was spent by the other company on doing the research and development of the drug, right? And to recoup their cost, this $11 billion of buying this company, it took them 263.49 days. 263.49 days to recover the 11 point something billion dollars that they spent. It's pure profit after that. Okay. And the price is 84,000. And country after country, this drug was available, but too expensive. So Malaysia issued a compulsory license for government because our government negotiated for 3 years, couldn't get the price down to something that was even close to be affordable. If it's so expensive, no matter how wonderful it is, nobody's going to be able to get treated, right? So the Malaysian government decided to issue a compulsory license only for government hospitals, right? And we got the drug for about $120 for 3 weeks. In the US, it's $84,000 for 3 weeks. Oh, sorry, 3 months for 12 weeks, 3 months. Yeah. Can you imagine? I mean, what is the price differential we're talking about here? Even if a country is richer, it shouldn't have to, their people shouldn't be having to pay that kind of a price, right? So, yes, I think the pricing, the real cost of R&D, how much is for advertising, how much goes to the CEO and the bonuses and the airplanes, yes. I think those are things that this is a public health. This is not a commodity, right? This is public health. It's about human health. It's about human lives. And if decisions about even what to research on and not to research on is left largely in the hands of a few private companies, then we won't get the kind of drugs that we really need. That's why millions of people, hundreds of millions of people who have diseases, but they're poor. Nobody's going to do research for you, right? Which is why you have a group called which is actually dedicated to do research for neglected diseases. And this is set up by a group of people who were from MSF, Medicine Sans Frontier. When they won their Nobel Peace Prize, they took the Nobel Peace Prize money and they used it as seed money. And so DNDi is this initiative for neglected diseases. And so they pick up molecules, they negotiate with companies. You're not interested in the molecule because somebody else already got there before you and there's similar molecule, give it to us, all right? We will even pay you some money, but license it to us and we will take the research. And they've developed drugs for lots of neglected diseases in Africa and other places. So we need that kind of model. Right. I'm not saying we don't have private companies. Of course, we need, governments are not going to be the ones running all the factories. Yes, but let's have something that is rooted in profit, but not only profit, right? But that reinvest back into the system. Because when the world comes to an end, right, the richest people are also going to get it. Nothing is going to save anybody, right?
Thank you, Yoke.
I don't want to end on a pessimistic note. I am very, very. I'm an eternal optimist. Okay, when we all work with people who are on the ground, who are patients, for whom we are the ones with the luxury of having choices. So I think we got to get our own act together, and together we can do a lot. And there are people in government. Yeah, lots of people in government. And they need us as much as we need them.
Yeah, so on that note, I think we have to close because we've really run out of time. We've exceeded 20 minutes already. Thank you, everyone, and thanks, Yoke, for all your patience and talking to us. We can just go on and on because I have questions coming in, but due to shortage of
I saw so many very interesting comments as well. So this is a very rich group of experienced people. So can you share those chat
the comments and
comments and share
it with you, and we will also share your presentation which you shared with us with everybody. My laptop was slow, so I could not open.
No, it's okay. It's okay. Yeah, but I might actually tidy it up and then give you the presentation. And
everybody who.
Yeah, I can add a few slides from some of the questions and comments. Yeah, and I can give that to you.
Thank you.
Okay.
Stay tuned in, everybody. Thanks for joining us.
Thank you.
We have one more web talk series coming up. Stay tuned in for more details. And Leo, would you like to give some closing comments? You have to unmute.
Yeah, thanks, Yoke, because despite not having the opportunity of meeting with you and sitting with you and listening to you, it feels like we are in your living room. Thanks for making it so personal and so immediately relevant at multiple levels. So we hope to have you soon in Bangalore.
I love
having, so and hopefully we can come there. So thanks for making it such a rich conversation.
Thank you. Thank you to everybody. I'm sorry we didn't really get to sort of, hear from more people. Sorry if I talk too much.
No, you were extremely articulate in explaining to us so many dimensions of this problem which we don't hear about and not often is it written about. So this is something that we are going to share very widely. I want to say that this video will be on our website, estindia.org, in a matter of a day or two. It has already gone live on Facebook. If you just type Environment Support Group, you'll find the link and you can share that link. It's also been live tweeted. My colleagues have been tweeting live on Twitter. Just find the ESG handle, E_S_G. And most of your main points are already tweeted. So
oh my God.
if anyone has missed out, you can just go there and just get a quick look at what Ling said. So brilliant.
Now I'll get all these companies after my back.
No, we made sure they will come after you.
Yeah. Well, thank you so much to everyone for being with us. Yeah.
Our next speaker next week will be somebody from the Americas, so we'll confirm in a day or two. Thank you. Thanks very much.
Okay. Bye.
Bye.
Good weekend.